See, we are going to deal with something that has came quite often in the exam last year as well. We are going to deal with congenital hypothyroidism plus cretinism. Cretinism, that is, say, endemic cretinism. There are some minor differences also, but first let's talk with congenital hypothyroidism. So there is less T3 and T4. So what may be the cause? One cause may be there is some problem related to the gland. Then there might be some problem related to the hormone synthesis. And there might be some problem that is related to the raw material for hormone synthesis. And then, of course, since it's congenital, maternal factors are always there. In glandular factor, we might have dysgenesis, agenesis, hypoplasia, or lingual thyroid, in which the thyroid basically cannot descend down from the base of the foramen cecum of the tongue. In hormone synthesis, we have TPO deficiency. In raw material, we have iodine deficiency, and this is what is known as basically my endemic cretinism. In maternal factor, we have maternal TPO antibodies that diffuse into the fetus, and then in maternal factors, we also have maternal use of antithyroid drugs. Clinical features, basically, if we see about the normal features of hypothyroidism, first of all, we will have something that is related to reduced mental function or alertness and activity of the child. Then what we will see is the thyroid hormone is responsible for the BMR. So here we will see reduced heart rate, reduced thermoregulation. So there will be hypothermia. Due to increased TSH, there will be GAG deposition that may cause puffy face, then hoarse voice, and then macroglossia. And then there are some specific features like umbilical hernia. Of course, due to this, there might also be constipation. So you have the heart and the bowel here. And then we'll have umbilical hernia, and of course there will be developmental defect. Developmental defect, there will be delayed bone age that leads to delayed closure of the fontanelles. So then investigations, thyroid function test, reduced T3, T4 leading to increased TSH. Then of course screening test we will do by serum TSH levels. Then we have radioactive iodine uptake, and of course we have thyroid USG. Then in management, thyroxine supplementation. It is almost 10 to 15 microgram per kg body weight per day. This prevents complications. The main complications being mental retardation and reduced growth. Now this is almost the same for all. Now just for here, endemic cretinism due to iodine deficiency, we have seeds of two types. We have the myxedematous type and the neurogenic type. The main difference in myxedematous type, basically goiter will be absent, and here goiter will be present. Neurological manifestations will be absent and neurological manifestations will be present. So what are the neurological manifestations? Low IQ, spasticity, then in eye we can see squint, in ear we can see sensorineural hearing loss that leads to deaf mutism. And here some characteristic features like loss of lateral eyebrow or madarosis. Then we have periorbital puffiness, coarse facies, and of course low IQ will also be there. So this is the main workup and everything that is associated with endemic cretinism and congenital hypothyroidism.